Welcome to All About Burns, powered by Healing Home Group.
This is the podcast where we dive into the journeys of burn survivors,
Chat with medical and mental health experts,
and share stories of healing and hope.
Now, here's your host, Corey Halstead.
Welcome back to All About Burns. I'm Corey Halstead, your host and fellow burn survivor. This podcast is all about sharing knowledge, stories, and hope for anyone touched by burn injuries. In our very first episode, we set the stage for what the show is about. Today, I'm honored to welcome a very special guest, someone who has played a key role in my own journey, Dr. Ryan Endress, a surgeon whose skill and compassion has guided countless survivors through some of their hardest days. Dr. Endress began his med school training at the University of Kansas. He completed a plastic surgery residency at Stanford University, and he also completed a fellowship in upper extremity at Mayo Clinic. Dr. Endress, thank you for being here. We are so honored to have you here.
Well, I'm honored to be here. I appreciate you very much asking me to join. This is very special, and I'm excited to be a part.
Now, Dr. Endress, before we get into the clinical side of things, I really would love for our listeners to hear your personal journey, how you began your career in medicine, where it all started.
Yeah, so mine goes back a ways. I kind of knew I wanted to do medicine even when I was very young, like 6, 7. My mom's got these Snoopy books, and I've circled all the medical words. And I remember cutting my hand with scissors and getting stitches and watching and just being fascinated. And I kind of knew I wanted to go into medicine. And then once I got to med school, I very quickly figured out that surgery is the path I wanted to take, surgery of some kind, and then kind of gravitated towards plastic surgery. They actually have a burn unit at the University of Kansas. So while I was a med student, I was able to participate on plastic surgery rotations with a lot of burn surgery. And then when I was a resident at Stanford, we actually work at burn center at Santa Clara Valley Medical Center, which is out in San Jose. And we spend, I'd have to do the math, but at least probably a year on burn and trauma, I guess, at the Burn Center at County Hospital as a chief resident, as a third-year resident, as a second-year resident. So a lot of burn experience, and, kind of developed a joy for treating burn patients, and then carried that forward here now, working out of Swedish.
That's remarkable, Dr. Endress. And, nowadays it's very hard to find great doctors, and you've been inspiration to me in my own healing journey. So thank you for all that you've done for me. So going to the first question, and I guess you kind of spoke to this, but what first drew you into burn surgery, and what keeps you passionate about this work even today?
Well, I think with burn surgery, there's more of a team and a family than really any other type of medical care that I've ever seen. There's multidisciplinary rounds every day, and everyone from the therapist, the nursing staff, nutrition, everybody involved with residents, PAs, depending on where you're at, are all in this one big group with this singular goal in mind. And everybody that does it is passionate about it. And there are so many different aspects to burn care that makes it so complex. It's very mentally stimulating from just a medicine standpoint. The surgery, as you've seen, that's a lot of problem solving. No two surgeries are the same. No two reconstructions are the same. So it's very, I guess, intellectually stimulating for me. And then to see people grow and recover, and progress, and then help others. I think that's what keeps me doing it.
You do remarkable work, and that's very powerful, because I think a lot of survivors, would love to hear how someone in your role finds both the purpose and strength in this challenging specialty. Burn injuries, it's very difficult, very hard, not just physically, but even mentally too. When a patient arrives with serious burns, what are the very first priorities for the care team?
Well, first and foremost, it's a trauma. Very often we don't know the nuances of the story. Even if somebody's found down, you don't know if they've been in an explosion or have a neck injury or any of these other things. So when they come into our ER, the emergency medicine physicians and the trauma physicians do their initial assessment, the ABCs, airway, breathing, circulation, et cetera, to make sure that the patient's stable and safe before we do our evaluation of, the burns themselves. And one of the critical components, and one of the things that I think Swedish does very, very well, is trying to avoid some of the pitfalls that severe burn patients could have with, contamination, be it, they've got diesel fuel or whatever. So we have a good decontamination space there in the ER that we can do right away. And the other thing is temperature, maintaining the normal body temperature, which is so critical because you lose good portions of your skin, then and you lose your body's ability to maintain moisture, but also thermoregulate. So people get very cold very quickly, which is not good for outcomes. So I think that's kind of the initial things is making sure there's no other life-threatening traumas, and then getting a handle on people's decontamination, keeping them warm, and then we can go into the actual care of the burns.
And is resuscitation, resuscitation, also something that's very important early on?
Yeah.
Burn injury?
Oh, 100%. So very often it's kind of a quaternary referral center, we get calls from all over the place for people having burns. I don't know the statistics, but I would imagine a minority of our big burn patients' first hospital is Swedish. Most are coming from other places. So we have to get a good idea from our referring partners, how big the burns are, how big the patients are, the mechanism of the burn, to know how we can start managing that fluid early. Because as you mentioned, resuscitation is very critical. Really, there's that kind of 24-hour time window, which is really key, because it's disastrous to under resuscitate and not give people enough fluid, but it's also, there's a host of things that can go wrong if you over resuscitate and get too much fluid. So there's a lot of nuance in managing that we do with our ICU partners.
How do you balance all that?
I mean, a lot of it is clinically related from how much urine a patient's making. We have an invasive monitoring through central lines that can detect, how hard your heart's working to pump fluid throughout your body, and know like how full is it, how hard is it pumping, where are we at on the fluid from that regard. We're following labs and transitioning between, thinner fluids versus, fluids that were called colloids that have, more structure to them and things, just to try to really balance that out. So we're giving burn patients enough fluid and nutrients, et cetera, to perfuse their organs or get blood to all their organs, but not so much that we get them, too swollen. Or
are there any common misconceptions families or even patients have about these first hours?
I think what the tendency is for people to underestimate the severity and how sick somebody's really going to get, because at the initial outset, even in a really big burn, patients it's certainly painful, but just from a physiologic standpoint, patients don't act super sick right off the bat. It's 8, 10, 12, 24 hours later where their organ systems really start to feel the effect of this major burn. So at first, somebody's walking and talking and answering questions and they've got a 75% burn, that patient is going to be very sick very soon. So I think that's kind of one of the misconceptions when people are like, oh, it's not that bad. But in reality, it's becoming very much worse very soon.
What kind of illnesses or infections could you see during that early on stage that people may not be aware of?
Yeah. I mean, infection usually isn't super early. Infection's usually a little bit of a delayed phenomenon, unless they come in with a pre-existing infection. But really early on, it's going to be issues related to the fluid. So kidney issues are very common early on, especially in people with pre-existing kidney disease or more elderly patients. That's why we try so hard to manage the fluid appropriately. And it's not uncommon for patients to need to be on like a form of dialysis, essentially, to help their kidneys along. Lungs, because of all this extra fluid and this inflammatory response, plus a lot of patients, if you're in an enclosed space when you get your burn, you can get what's called an inhalation injury and your lungs can be severely damaged. So a lot of people have issues with their lungs, and that's why almost every major burn gets a breathing tube for a period of time to support their breathing, et cetera. So those are kind of the main kind of early things that we see.
Dr. Endress, thank you. Moving on to skin grafts. Skin grafts can sound intimidating. How do you explain split thickness grafts and also full thickness to patients and families?
I mean, there's lots of different analogies that we can use. And being a podcast, it's hard because I use my hands a lot when I'm trying to describe this stuff. But I essentially, when we talk about burns, a lot of people thankfully have burns that don't burn through all of the layers of skin. They're very superficial. It's like mowing the grass, but leaving plenty of grass left behind, so that even though you kind of scalp your yard, you have roots in the bottom layers of grass to grow it back. It just takes time. And that's like a second degree burn. Now, a third degree burn is deeper. That's like getting into the roots where the grass isn't going to grow back on its own. So you have to do something to get your skin back. And that's where skin grafts come into play. And we've got a myriad of things that we can do to try to maximize how much skin we have, because in a big burn that you're looking at shortages of real estate to harvest skin because, a majority of your skin is burned and you obviously can't transplant burned skin. So the mainstay is what's called a split thickness skin graft, meaning we take enough of your yard down that we can transplant it somewhere else and grow new grass and grow new skin, but we leave enough behind that it can still heal. So we're robbing Peter a little bit to pay Paul, but Peter can still, grow back on his own. A full thickness graft is where you're taking literally the full thickness of skin so it can't grow back on its own. So those donor sites where you take that full thickness skin graft, you basically have to sew closed. So it's very limited on how much skin you can take. The benefit being the thicker the graft is, the less it contracts and the better it looks. So if we had an unlimited amount of full thickness skin graft, we would use it. But the fact is we just don't. So we're stuck using split thickness skin grafts for a lot of things. Now, that being said, there are some excellent products out there that can form a neo or a new dermis-like substitute to give you some of that pliability and stretchability that a full thickness skin graft has while you put a split thickness skin graft on top. So we do have kind of tricks that we can use to simulate a full thickness skin graft, but that's kind of the basics of skin grafts. So split thickness grafts are thinner, they contract more, but they can cover a much, much bigger area.
Split thickness grafts. You also do what is called meshing.
Correct, yeah.
So can you explain to us what meshing is and why doctors do this?
Yeah, so it takes the graft and you put it through a little machine that has different ratios of a mesh, like 1-to-1, 2-to-1, all the way up. I mean, you can get 9-to-1 or 6-to-1 if you do what's called Meeks, but that basically puts regular alternating cuts in it to make it look like a mesh, true mesh, like an old school football jersey kind of mesh that then allows you to basically take a skin graft that's say 10 by 10 and spread it into 20 by 10. So you get more surface area for a given amount of graft that you have. The downside being the wider you mesh it and you open it up, your body has to kind of heal all those little spaces, those open spaces. So the wider the mesh is, the more it contracts and the worse the scarring.
And you see a lot more scar tissue form where those meshes were in place. At what point is a contracture release considered? And what does recovery usually look like afterward?
It's kind of variable depending on the person. Usually it's at least a few months after you've healed because you want that scar to have a little bit of time to mature and get out of that inflammatory phase of healing. But once you develop a contracture, it's not going to reverse on its own. So then you have to release a scar. You want to get back into healthy tissue. And then depending on where the scar contracture is and how big the deficit's going to be when you release it, that kind of determines where you need to go. So smaller things like, in hands, we can just rearrange the tissue to eliminate the contracture without having to do any additional grafting. And if we can do that, that's preferable because that is really thick tissue. It's very pliable. The healing's very fast. If it's smaller areas, again, hands, faces, things like that, then we can do little full thickness skin grafts if those donors are available. And then bigger ones require, like the products we talked about, skin grafting, wound vacs are, utilized at that stage, which is kind of a negative. It's a sponge on suction that, holds things down tight. And then depending on what we had to do to get to reconstruct, the time of recovery from those releases is variable, very often splinting. For armpits, we do a lot of contracture releases. You're in a splint that holds your arm up for weeks and weeks so that it can heal and not immediately contract back.
Now, are there any areas in the body that are more prone to contractures?
Yeah, really anything over joints. So hands, armpits, necks are kind of the most common that we see.
What is a burn survivor? What can they do early on to prevent their scar contractures?
Yeah, I mean, it could be mitigated with stretching and therapy. That's why patients meet therapists basically day one to get splinting in the appropriate position. I mean, a lot of it, though, is what we do as providers and how it's treated initially, like the thickness of grafts, the timing of grafts, the types of grafts, that sort of stuff play a huge role in whether or not contractures develop and then how it heals. I mean, if you get an infection or you have delayed healing, more likely to get a contracture. So from a patient standpoint, it's just really being diligent with therapy and splint.
Managing pain and anxiety can be one of the hardest parts for survivors. What approaches have you found most helpful in the hospital setting?
We have mental health professionals that we work with that are part of that multidisciplinary team I talked about that are involved right away. I mean, almost every major burn has an acute stress reaction that our professionals help manage. And some of it's just communicative between patients and families and our mental health specialists. Some of it is, via medicines to help with certain aspects of mental health and stress and things like that early on in the post burn recovery phase or in the reconstructive phase even. So those are kind of huge roles. And then it's really just a clinical interaction with patients and families and determining what the needs are. And once we figure out what the needs are, we know how we can address them.
Now, do you see survivors having more challenges once they get out of the hospital in terms of like the mental health aspect of things?
I mean, I think it's very much patient dependent. Some people do have a harder time in the hospital setting or in the rehab setting or nursing home, skilled nursing facility setting. And then once they're able to get home, it's easier for them. For others, I think it is more challenging when you get back out into society and back home, because a lot of patients do have, a visual difference to the way they look compared to when they went out. And people struggle with, recognition and change from previous peers and friends and groups they used to be involved with. And, even meeting new people and trying to get exposed to new situations and environments is a challenge for a lot of people. So we have a number of resources, probably not enough to help with that, but
Once patients go home, therapy and movement really become critical. Why is early rehab so important, and how can survivors stay consistent?
I mean, rehab is so important to prevent the issues with contracture, like we talked about. And even in the absence of contracture from the burn scar, just by virtue of being so swollen in the hospital phase, oftentimes being intubated or not able to actively participate a lot in therapy day to day, just leaves your joint super stiff and swollen. So even if you didn't have a burn over your whole hand, you can still have limited mobility in all those little small joints. So early therapy helps mitigate some of those issues. And then keeping people on track is, number one, having resources available so they can see an outpatient therapist regularly, developing a routine. Every commercial, I'm doing this exercise, or when I brush my teeth, I do this, things that you can just regularly remind yourself until it becomes habitual.
What daily habits or even simple routines can really make a difference in healing at home?
I mean, the therapy routine, nutrition is absolutely critical. Almost every patient in the hospital gets a feeding tube for a long period of time because your body has to work so hard to heal, the burn wounds. You leave the hospital, you don't very often leave with a feeding tube. So you need to keep up your protein, your vitamin intake. So I think healthy eating habits, exercise, therapy, and then, mental health routines to keep yourself in a good headspace so that you can participate and do all these things that you want to do.
You mentioned something about healthy eating. I remember early on being in the hospital, they had a very high intake of protein. What was the reason for that, and how does that benefit, recovery?
Well, the way your body heals these wounds is essentially by utilizing proteins, reorganizing those and building in different collagen-like structures to heal new skin, heal, muscle and, all the parts of your body that basically are involved in the healing process require this protein building blocks essentially. So high calorie, high protein is critical.
Let's talk about scars for a moment. Scars are a lifelong reminder of what we've been through. How do you guide patients in setting realistic expectations for how their scars may change over time?
Scars are very fluid, I think, long term. There's a lot of change that happens. Some of it's very predictable and some of it is a little bit less predictable, depending. I mean, I think having clear expectations at the outset, I think, is very important. If you have a third-degree burn deep enough that you need skin grafting to heal it, you're never going to be scar-free. The idea is that between the provider and the patient and the available treatments and therapies, we can minimize the amount of scarring, not only to have the least amount of impact on function, but also to have the least amount of impact on the cosmesis, and try to look as good as it can. So the scars are not maturing for a minimum of a year. I tell people, I give it at least a year before you consider a scar even close to being fully matured. And the thicker and more, expansive the scar and the longer it takes.
Now, there's different types of scars. There's hypertrophic scarring, there's keloids. Can you talk about that a little bit for everyone?
Yeah, so hypertrophic scarring is essentially a really thick scar that's thicker than you would normally anticipate for the healing process. It happens very often around joints or areas that have had wide meshing that need a lot of what's called secondary healing. Keloids is essentially a really bad, it's not truly a hypertrophic scar. It's different than hypertrophic scar, but they look similar, but a keloid expands beyond the borders of what anticipated to be. So that's something you very often see with even minor trauma. Like you get an ear piercing and you're a keloid former, you form a big, marble-sized knot of scar. That's a keloid. A hypertrophic scar is if I get a cut and it heals and it's really thick and wide, but still within the borders of that cut, that's a hypertrophic scar. Managed slightly differently. In the burn population, we tend to see hypertrophic scars a lot more commonly than keloids.
Are a certain type of demographic more prone to hypertrophic or keloid, like ethnic background or?
Darker pigmented individuals tend to form keloids more often. Hypertrophic scars, to some degree, are a little bit more common in the darker, higher melanin content, I guess, skin types. But really, the hypertrophic scars are more related to just the healing process, the nature of the injury, tension across wounds, things like that. So more non-genetic factors.
At what point would you recommend secondary treatments like laser, be some reconstructive revisions, or fat grafting?
I kind of like that 3-month window because it gives us enough time for us to start waning kind of out when the scars are less pink, less inflamed, a little bit softer. I think you get more predictable results when you wait that long. But yeah, I mean, those are all things that we do very frequently. Lasers are great for the more superficial aspects of scars. They can help soften scars. We use them a lot on hands and faces in areas with true scar hypertrophy. So very common.
What does the lasers do? I know there's CO2 lasers, and then there's IPL.
Yeah, IPL is more of a light. It's not a true laser. There's CO2 lasers, there's Nd:YAG lasers, there's lots of different types of lasers that have a particular target or chromophore. And like a CO2, for instance, is water. So it basically, the wavelength of that laser targets the water, selectively heats up the tissue we want to heat up, that then kind of generates remodeling, essentially. So we don't like mow the lawn with it. We're aerating the lawn with this laser to try to help the scar kind of soften and remodel.
What other reconstructive procedures would you consider after you do the initial skin grafts to a patient? What are some of the more common reconstructive procedures that you see?
Yeah, I mean, the contracture releases, like we talked about, is very, very common. And then there's other things to resurface. You've got a bad hypertrophic scar that's pretty expansive over a neck, for instance. Remove the scar and then you're doing secondary procedures to resurface that. And that's very often with flaps or grafts, like we talked about. Tissue expanders are used sometimes. That's essentially putting what amounts to a sterile water balloon under your tissue to help expand normal skin, and that can then be used to stretch over an area that has a burn scar. So we do that somewhat frequently as well.
So recovery isn't just physical, it's also deeply emotional. What signs do you watch for that a survivor might need extra emotional help?
We're always looking for signs, but we also involve our mental health team in essentially every patient, and basically everybody gets screened to make sure, because it is so prevalent, because it's such a devastating injury. A majority of major burn survivors do need extra, mental health resources involved. So I think we are baseline screening everybody. Signs I see very often: loss of motivation. I've got a patient that's really coming along very well, and then there's kind of like, not necessarily a switch, but a change, and less participatory in therapy, less conversant when I go around on him, in the hospital every day, less talkative, more withdrawn, things like that. Can clue us in that, hey, maybe what we're doing is not working. Maybe we need to take a different tactic or reevaluate where we're at and how we can help.
Now, as you see patients throughout your time at the hospital, what is some encouragement that you might share with patients who feel stuck or frustrated in their own journey?
I mean, just having the experience, I guess, and having the stories and the examples that we can provide of patients that have experienced similar situations and come out on top at the end, and also having some of our patients that come back through. One of the benefits of having our clinic not in the hospital building, but hospital adjacent is, we can see my burn survivors, and then they'll go back to the burn unit because they want to, reconnect with the burn nurses and the burn techs and the whole team. And then they also can see some of the patients that are inpatient, give some, reassurance and guidance to those patients that are still going through those initial phases of their burn recovery.
Do you see having peer support, I guess, part of the toolbox at the
100%.
hospital?
Yeah, for sure. No question.
What's one myth about burn care you'd love to correct for survivors and families?
One myth. What was yours? Did you have a myth? Was there anything that you that was way different than you thought it was going to be along your journey?
I'd say the overall healing journey of the skin grafts. I thought the skin was going to look the same. The split thickness skin, it feels totally different than full thickness skin. So I guess that was kind of a thing for me in not knowing what the end result was going to look like.
Yeah, I think along the similar vein, I would say, scarless. People are looking for scarless surgery, and I think that's a myth because once you get to that point, we're doing what we can to minimize the scar, but it's never going to be scarless.
Now, on the flip side, what's one truth that doesn't get enough attention in burn recovery?
I think that, like you mentioned, that the mental health component is just so huge. I think that it's almost universal that we're going to need some resources and we're going to need to help people through a mental health journey. It's very rare to see somebody that, doesn't need some sort of assistance in that realm. And even then they probably did and just masked it very well.
Now, what can families do to help support their loved ones that have experienced such a traumatic injury like a burn?
Just being supportive, being present and being supportive, giving assistance with some of those little things that we take for granted day to day that somebody that's recovering from a burn may find challenging, right? They may find it a little bit embarrassing, or, they may not accept well the fact that they can't do XYZ. They've got burned hands and I can't brush my teeth right now. I need some help, and just be willing to jump in and not be judgmental and be supportive and just an available resource for patients, I think is huge. And then just, I guess, trying to communicate with the team, especially in the inpatient setting, questions come up and things. And I think sometimes just communicating well with the team, I think is critical.
So looking ahead, what developments in burn care and research make you most hopeful over the next 5 to 10 years?
I think a lot of the technology space regarding, our ability to increase graft survival and spread the amount we can cover with existing skin in a way that's not going to result in these severely hypertrophic scars is helpful. I think there's going to be a change in that and how some of these skin substitutes or replacement dermal matrices play a role in the acute burn care and not just the reconstructive burn care. Trying to mitigate some of the hypertrophic scarring and augment and speed up some of the healing. I also think we're making headway in some of the pain management of burns because that's such a huge component of burn care and being able to better manage, non-narcotic medication, essentially.
What about regenerative medicine in terms of regenerating full thickness skin? There's some companies out there that are in clinical trials right now. Do you foresee this something being the new standard of care maybe 10 years down the road?
Yeah, I mean, I think it will certainly be time. That's probably not a 5-year thing, but I think if those companies can achieve the growth of the skin, thicker skin in a timely fashion, I think that's going to be key. You have to have something that's biocompatible with that patient that you can have available within that window of grafting in the first few weeks so that they don't start to develop these contractures and hyphic scars. I mean, right now, we've had CEA for a while. I don't know if that was a component of your care, but it's cultured epidermal autografts. And that's where you can harvest small pieces of skin, full thickness skin from a patient. They get sent to the lab and then they grow epithelial or just the outer layer of skin cells on sheets that you can then put down to help heal those interstices and those widely meshed grafts. That takes a long time to heal and it's just not super durable. It's, very friable. It's prone to contracture. It's prone to breakdown. So if, somebody can come up with a solution that's a thicker, more durable skin that could be readily available like that, yeah, that'd be a game changer.
Dr. Endress, this has been an incredible conversation. Before we wrap up this episode, I'd like to ask you one final question. If you could speak directly to a new burn survivor on day one of their journey, what would you say?
I just say we're going to be here with you every step of the way. It's going to be a journey, but you're not alone, and we're going to be here with you and get you what you need so that you can heal and get back to where you want to be.
Thank you, Dr. Endress, for sharing that. And thank you for being with us today, not just for your expertise, but for your compassion, your experience that you bring. You help us survivors, and we appreciate you. I appreciate you. How do people find you if they're needing care and they're needing expertise like yourself? How can they find you?
Well, we have the best burn unit that I've ever been a part of at Swedish, and we're available 24/7, 7 days a week. We have a referral center and a whole team of people willing and able to take care of any patient you call. We've got now 5. I don't know if you knew this, but we have a new partner that's coming on to join the group in November. So we'll have 5 dedicated burn surgeons and part of the greater team to help any burn patient that needs it.
Where exactly is Swedish?
So Swedish is in Inglewood. It's kind of just the south part of Denver. It's a level 1 trauma center, HC hospital, and it's readily accessible. We're always available.
Well, thank you, Dr. Endress. To our listeners, this is why All About Burns exists, to bridge the gap between medical knowledge and also the survivor experience. I'm Corey Halstead. Thank you for tuning in. Don't forget to subscribe, share this episode, and join us next time as we continue to explore the journey from injury to healing. Until then, stay strong and remember, you're not alone.
Thanks for tuning in to All About Burns.
Brought to you by Healing Home Group. Be sure to follow, subscribe, and join us next time. Until then, take care and stay strong.
And remember,
You're not alone.